Good morning, everyone. Welcome to the first session of Skill-A-Thon, which is emergencies in office practice. I welcome Dr. Suresh Gupta. He's a senior consultant and co-director, Pediatric Emergency and Critical Care in Sir Gangaram Hospital. He is also a convener and chairperson of IAP-PM chapter and the ex-president, Society for Trauma and Emergency Pediatrics. He's also the ex-president, IAP Delhi branch, and executive member of Central IAP in 2016. Welcome, sir. I also introduced Dr. Prerna Batra. She is the Director Professor, Department of Pediatrics, UCMS and GTB Hospital. She is the course co-director of FACI, executive member of AC, convener Academic Council IAP PM chapter, and a member of Delhi State AEFI committee. Welcome, sir. I think sir will take the first topic, which is emergency preparedness in pediatric office. Welcome, sir.
Good morning, everyone. I think on such a rainy day, so many people are able to gather. That shows that people are really interested in managing the emergencies. Let me know how many of you are in hospital practice or how many of you are just in office-based practice. Dual practice rather. I think those whoever are doing office-based practice, they must be doing their own practice also. So what is an emergency first of all? When you talk of emergency, what is an emergency? How do you define an emergency? Okay. Any more input? Right. You want to say something? So this is how we understand, most of us understand what is emergency is. Emergency is a life-threatening situation. If you see our emergency room records, whether it's tertiary care center or public sector or government sector, I will tell you not more than 5 to 10% of them are having any life-threatening situation. And Dr. Prerna can vouch with me. Dr. Prerna, do you agree with this? How many of them are really have life-threatening situation? Very few of them. 80 to 90% of patients who are landing in emergency room are not having any life-threatening situation, but still they are coming to emergency room. So, for an emergency physician, pediatric emergency is whatever it needs a immediate medical attention. It's an emergency. A child who is crying in the middle of the night with otitis media, it is an emergency. So, scope of emergency goes much beyond than life-threatening situation, and often you will encounter those kind of things which are not even mentioned in the book, and you have to be a little innovative in dealing with that. Looking at this child, you will say definitely this child has got some life-threatening situation. Child is cyanosed, unconscious, more like a very shallow breathing. But what about this child? This child has come in emergency room. It's a real case, right? Is this a life-threatening emergency? No, there is no threat to the life, right? But it's emergency. And you will not find treatment of such emergency in any of the surgical books, let me tell you. So you have to be innovative. This child has screwed himself, I can say. Right? So we have to prepare ourselves. Now I'll mainly focus on non-life-threatening emergency. So don't get scared by all these mannequins and thinking that I'm going to teach the CPR. The chances of doing a CPR in a clinic is very, very rare. I don't remember resuscitating any child in my office. Maybe anyone who has done the CPR in office? Very rare chance, right? So I'll just leave that because they have told me to focus only on office emergency. Right? So we have to prepare ourselves. Why it is important to prepare our office for the emergency? Because it's important for child life, child limb, child pain, and to make the patient more comfortable. And socially it's important actually. We as a guardian of the children of society have to take care of them when they are not good. Ethically, morally, we are bound to deal with that. Medico-legally, many of our colleagues have already faced many medico-legal challenges. And professionally and financially is important for us, all those in practice. So I will not start with the equipments. I will start with the help, how to seek the help. Right? Right. These are the numbers which should be there in all the clinics. Right? Right? Delhi Police, Ambulance, Poison Information Center, which is working in the Delhi Institute of Medical Sciences. Right? And number is very easy, 1800 116 117. It runs 24/7 and provides very useful information when you encounter a child with poisoning. And another center which is running at CMC Vellore, and you can just note down the number. And child helpline, particularly when you encounter a suspected child with child abuse. For POCSO point of view, medico-legally it's important that all such children who have got suspected sexual abuse should be reported on this number. And our number is not 1098, it's 1098. Let me tell you. The government written this number so that all the children can remember it actually. 1098. Right? And this is regarding child. But sometimes even doctors are in emergency. And you have to save yourself. And for that, you have to have liaison with a nearby hospital. Whichever near hospital, have in advance talk with the pediatrician who is working over there in case I get some emergency and I have to refer, okay, or transfer the child, will be able to take care of that. Liaison with your friends, nearby doctors, right? In case some hangama happens in your clinic, are they going to help you to rescue you, not the child to you? And don't forget the nearby police station. Have a good liaison with SHO. At least meet once in a year with the SHO of the nearby police station. So when you are dealing with a medical legal situation, they can be very helpful. So 7 steps for office preparedness, office-based assessment, what is the response plan, training, triage, equipment, medication, transport, and documentation. Office-based assessment, you decide what kind of emergency generally you deal with and what are the resources you are going to keep and how much capabilities you have and the closure facility. And so, no, oblique, there are 2 numbers actually. Sorry, I think I written one, sorry, I think I written this thing. This number is, on करना है. I'll tell you what. 116, 117. It's not oblique. Slash which I have put is wrong actually. So you train at least your front desk staff to handle how to handle emergency, how to apply oxygen bag, how to do the embo bagging, at least basic things should be, and most importantly, which number to call when you tell him to do that. We can leave this part. Training, front staff and yourself also, trials, children already in office or telephonic trials, medication, right? And equipment. In medication and equipment, you all know all the common emergency drug. Adrenaline is the most important drug. Adrenaline is the most important drug, not from CPR point of view, but basically from anaphylaxis point of view. Chances of seeing a cardiac arrest is very, very rare in office, but chances of seeing a anaphylaxis is not that uncommon. And of course, group, ambu bag. In addition, activated charcoal, which is easily available nowadays. You can get from any chemist, it's not very expensive. And at least ambu bag with oxygen, all of your nebulizer, all of you have that pulse oximetry, we can leave that. Transport, equally important, and I think I've mentioned all these things from Midazolam. And whenever, whatever emergency you are handling, at least document in your clinic on some paper or a laptop what all you have done, because medical legally it will save you. So consequences of being unprepared are very serious. Initial treatment provided in the office may mean a difference between life and death sometime, and other times you may make the child more comfortable. So this is a brief introduction regarding office preparedness, and with this I invite Dr. Prerna. Dr. Prerna is heading Pediatric Emergency at University College of Medical Sciences, and she is the true emergency physician. The reason being, I called her only 24 hours back, and she was ready to handle my emergency, to come to this.
Yeah, thank you. I would like to thank first the organizers for giving me this opportunity, but yes, it was really an emergency situation for me too. I had to really rush in a day to prepare for this. I would say less than a day. So just bear with me if there are some little errors in the presentation, basically the written part on the PPT. So I'd be discussing about the common medical emergencies that you may get in pediatric office practice. We'll be discussing 3 important cases that are quite likely to happen when that you may quite likely encounter when you are dealing with your OPD patients. So this is a very common case. This was apparently healthy 3-year-old child who came to you for immunization, for vaccination. You gave flu vaccine and you find that after 15 minutes that mother rushed to you with some problems that the child is having, and these problems may be in the form of vomiting, cough, noisy breathing and rashes. So this is quite a common presentation. I would say it appears that this appears to be an anaphylaxis reaction, but more common than anaphylaxis is the vasovagal shock. But the presentation will be different. So vasovagal shock is milder form, much more common than anaphylaxis, but it has just changes in blood pressure, maybe some tachycardia, you may get low saturations and there will be a fainting attempt. But the classic presentation of anaphylaxis that I will be telling what are the criteria that makes a child fit into anaphylaxis, those are not there in vasovagal shock. Vasovagal shock is a really mild but much more common condition. So when you examine this child, you find that respiratory rate is 46, slightly more. There is tachycardia, blood pressure appears to be normal, though CFT is borderline, it's just 3 seconds and saturation is normal. So your approach, whether you are in office or you are in a proper ED in a hospital setup, you should always try to approach a child in your ABCDE manner. That should be your aim in the OPD itself. At least follow your primary survey protocol, ABCD, and you will not miss anything. So when you examine this child following this ABCD protocol, quickly you can find out that there is Inspiratory Strider, some secretions might be there, air entry was equal, but you can auscultate rhonchi. There was tachypnea along with rhonchi. Child appears to be flushed. There is facial edema. So everything appears to be red. Appearance of the child's skin appears to be flushed. Child is irritable. Sugar is normal. D always includes dextrose in pediatric patients. And you find that on exposure there are generalized rashes. There is no history of previous such episodes. So you examine the child something like this. There are rashes. There may be facial edema. There is swelling of lips. Eyes may be swollen. And child is breathing fast. This is characteristic finding of anaphylaxis. So you define anaphylaxis when any of the following three criteria are fulfilled, like there is sudden onset of skin and or mucosal changes which were there in this patient with either acute respiratory symptoms in the form of wheezing, stridor or hypoxia, or there may be cardiovascular symptom in the form of hypotension, or there may be syncope, which is again a feature of end organ dysfunction, and there is sudden onset of any of the sudden involvement of any of the two organ systems after exposure to allergen. So इसमें GIT, like there may be diarrhea, vomiting, or there may be mucosal involvement or respiratory involvement or CVS, or there is age-specific hypotension, which is like 30% decline in the blood pressure as compared to the previous one. You might not be knowing the previous blood pressure, so this might be difficult to identify, but first two things are very clearly features of anaphylaxis, which you'll be able to identify if you are going in a systematic approach. Cutaneous symptoms, if you look at this definition, are not really necessary to make a diagnosis of anaphylaxis. So even if there is an attack of syncope with diarrhea, vomiting, some respiratory symptoms, you can know that this is an anaphylaxis. And these cutaneous manifestations are not always present. They are present only in 85% of the cases. So not a mandatory feature. Management in these patients is rapid cardiopulmonary assessment, and airway assessment is the most important thing, which should be done early and should be re-examined again and again. Not that once you have stabilized, child will not land up into respiratory problem again or airway problem again. So it should be reassessed again and again whenever you are having even if you have stabilized the patient, given the first line management, then also your reassessment should continue. If there is no impending compromise, as I've told, re-examine and re-examine. If the patient requires an airway, as Sir has told, try to have a liaison immediately with a hospital where you can send the child, apart from your starting the first line of management. So first drug that you would have to have in your office is epinephrine. This is the life-saving drug. Sir has already mentioned that this is something which should be there because this is useful in many conditions. This will save the life of the child, apart from your equipments in the form of ambu bag and oxygen. So these are the things which should be available, because immunization is something which you will be doing all the time. And most commonly you get patients of vasovagal shock and anaphylaxis following immunization. So in your immunization clinic, in your practice, you should have oxygen, ambu bag and epinephrine mandatorily as the support that you can have. So for anaphylaxis, epinephrine is to be given IM. We'll be focusing on the drugs which do not require intravenous administration, because at times it is difficult. If you are able to give, then you can manage one much more, but in OPD it's not really possible. So we'll be giving IM epinephrine, that is the drug of choice for anaphylaxis. Your dose, this ampule comes as 1 in 1000 dilution, so the dose becomes 0.01 milligram per kg. Maximum is up to 0.5 milligram. You don't have to dilute it. As such, the ampule of 1 in 1000 you can use. You can repeat the dose every 5 to 15 minutes if the child is not improving and requires more. If there is stridor, you can see or you can hear audible stridor. Stridor is inspiratory sound that comes through the upper airway obstruction. So there is laryngeal edema which may give rise to stridor. If stridor is present, you can start with epinephrine nebulization. Racemic epinephrine is what the textbook says, which is recommended, but it's usually not available. So what you can do is that simple IV epinephrine that you have in your clinic that can be used. It can be given in 1 in 10,000 dilution as well as 1 in 1000 dilution. So there are no really very definite protocols, but this is what you can start with for nebulization in your office if there is audible stridor, like you are suspecting airway obstruction. So first thing that you have given is IM epinephrine, and then if there is stridor, you are suspecting airway narrowing, you can start with epinephrine nebulization. Then oxygen support is required. If there are audible V's, you all have facility of giving salbutamol with nebulization. You can start with that. At times, IV may be required if there is obvious cardiovascular compromise. So that can save the life if you are able to provide an NS bolus of around 10 to 20 ml per kg over 5 to 10 minutes. That may save the life, and child will not land up into frank shock if you are able to identify the compensated state and give one bolus of normal saline. Second line treatment, I would say that might not be required in OPD. You should be able to transport your child safely after stabilization to a setup where proper emergency is available. But just to complete the list, if there is delay, you can start with corticosteroids. Corticosteroids basically act late. They will help in reducing the inflammation. Onset of action is late, so they will not help at that particular time, but definitely they'll be helpful in later states where that inflammation will be reduced. You'll be the action of, if you give steroids in time, onset of action will start. There will be immediate onset of action, though the help may be seen after 4 to 6 hours of administration of steroids. So if possible, you can give steroids as well. So the options include methyl prednisolone, and if it is not available, simple oral prednisolone. One dose if you are able to give in office practice, this will help the child later on in preventing further complications. Antihistamines, both H1 and H2 antagonists can be given. So you can give diphenhydramine or ranitidine later on as the second line drug. So this was about anaphylaxis. As I have told you, anaphylaxis is less common than vasovagal shock, but you should be able to identify because this is the life-threatening thing, and if you managed in your OPD well, then the child will definitely be saved. Now we come to the second case. This was a 1-year-old female who was brought convulsing to emergency or your OPD with history of fever for last 6 hours. These are multifocal seizures. They started 5 minutes ago, and child appears to be in altered sensorium. So your routine OPD patient may come to you like this. Here, establishment of diagnosis is not really very important. That will help in giving the long-term prognosis or the diagnosis ultimately, but your aim in OPD should be again to stabilize the patient, because this is a true emergency. Seizing child is an emergency, so that no harm is done and you are safely able to transport the child to a proper emergency setup. So when you examine this child, we again follow our ABCD approach. That is mandatory. You should do this. So airway appears to be maintainable. We have read in our piles, you must have all done that, whenever you examine airway, you try to identify if it is maintainable or it is not maintainable. Maintainable with severe simple maneuvers, or if it is maintainable with advanced maneuvers. Advanced maneuvers include endotracheal intubation, but simple maneuvers include, like in a seizing child, there may just be pooling of secretions. So if you turn the head to the a bit laterally, these secretions will be pooled in the cheek, and you can just simply wipe off. You can do it in OPD. It's not a difficult task. So you'll be able to maintain the airway in a very simple way. Then the child is spontaneously breathing, saturation is slightly low, 95%. If you have oxygen, you can put it. There is tachycardia, CFT is okay, the child is convulsing. If you are not, like GCS is something which is used for assessment of consciousness, but a simpler form is AVPU. So AVPU scale, where you just have to identify if the child is awake, if he is responding to verbal stimuli, if he is responding to painful stimuli, or if he is unresponsive. So AVPU, simple way, rather than going into the complications of GCS scale, you can just identify how sick the child is, what is the level of consciousness, and you can look at the temperature. This child was febrile, and this though appears to be febrile seizures. So one has to take a quick history where you want to know if the child is having fever or not. Is it a known case of seizure disorder? Why it is important, though your acute management will remain same, but it's important to upgrade the drugs. If you are able to stabilize a child, you can just send home by upgradation of drugs. Therapy may be required. You might have to increase the dosages. So all those things can be done if you know the history. If there is any history of trauma, if child has taken any medications, there may be some toxic which is associated to seizures. So all these history, whether the child was developmentally normal or not, so these things have to be taken. History, just a very quick history. But importance again is the seizure control. You have to control those seizures. So drugs that are available apart from IV route include Midazolam, which can be given through buccal route or through intranasal spray. Intranasal sprays are frequently available now. They are often, most of the medical stores, good medical stores, they have intranasal Midazolam spray, so you can get it. Per rectal, you can give diazepam, which is there. It is available as diazepam suppository or a diazepam rectal gel. IV route, if you are able to establish, then you have options of Midazolam and lorazepam. Dosages are mentioned here. So this is the Midazolam nasal spray, which is most frequently advised. So in INR, it is available at the cost of around 350 to 450 INR, which is not really very costly. It's a 5 ml spray. If you look at the dose, 0.2 milligram per kg per dose is the dose. So let's say it's a child who's 10 kgs, dose will be 2 milligram. And 0.5 milligrams is the one puff, so you can give 4 puffs in this case for a 10 kgs old child. So that's how you calculate the dose. This is a 5 ml spray. You can use rectal diazepam, which is available as rectal gel or rectal suppository. These can be used, these are available. Important thing is just turn the child laterally, squeeze in the drug and try to approximate the buttock so that the drug does not come out and stay inside for some time. Then parenteral preparation for diazepam, you have this injection which is available. In case you don't have gel, you don't have a suppository, this simple ampule of diazepam can also be inserted rectally and this can work. So this is what we have all the places. This was about seizing child or a child when he comes to you with seizure. At times prophylaxis administration is also required in OPD. So for prophylaxis you can advise mother about diazepam, rectal diazepam or diazepam suppository, Midazolam nasal spray, or even what I have seen in periphery. I was working at Vardha a long time back. So I had seen that some practitioner used to advise a pendant which used to have diazepam. Midazolam. So they used to keep it as a pendant in the patients who used to have febrile seizures or seizure disorder, and they were trained कि आप इसको डाल दो और school में भी ऐसे कर दे. So these are simple maneuvers that can be advised to kids who have these kind of things and who are able to manage. School में आप teachers को बता सकते हैं कि this kind of thing can be there. So these are more important tabiz than the usual tabiz that patients wear. I come to the third case. So this was a 14 months old male who was brought in by the mother with history of fever and cough for last 2 days, noisy and fast breathing for 3 hours. So what do you think this could be? Noisy breathing, fast breathing. Whenever we talk of noisy breathing, दो चीज़ आती हैं. One is the wheezy child and second is the stridor. So stridor is really acute, it is distressing. There is this upper respiratory sound. This kind of sound is there, this is stridor. So if you have this kind of thing, this again becomes an emergency. You examine the child, this child might appear to be sick with an audible inspiratory stridor. Stridor is mostly inspiratory sound. Airway in this particular case was maintained. A maintained airway can be identified just by hearing to the voice of the child. If child is crying, it means airway is maintained. Then you don't really have to bother about it further. But this child is at risk of airway compromise because you are suspecting laryngeal edema. So at particular time, at this time, airway is maintained. Child was having respiratory distress with supraesternal subcostal retraction. Supraesternal retractions again indicate that there is upper airway problem. Circulation is normal, child is conscious, but no other significant abnormality is found. So this gives you a clue that this child might be having croup or laryngotracheobronchitis. So it is an acute clinical syndrome which presents with inspiratory stridor, barking cough. There may be hoarseness of voice, variable degree of respiratory distress may be there. This is usually preceded by fever, coryza. Most of the time croup is viral in origin. So you'll get a history of mild cough, cold, coryza before the onset of these acute respiratory symptoms. They often start and they become worse at night, and child have the risk of rapid clinical deterioration. Commonest cause, as I've told you, is viral. All these parainfluenza, respiratory syncytial virus, adenovirus, these are responsible for it. Less common ones are brachial tracheitis and epiglottitis, but these are much more problematic. Is to have or life as well as patient's life. So is of choice. Epinephrine if it is there, or 0.5 ml kg of per kg of epinephrine will help the child. You need to provide oxygen. You can use face mask. Try to give anything that makes the child more irritable. At times we are trying to put prong. It will make the child more irritable, so that should be avoided. Keep the child calm, keep the child in mother's lap only, and give oxygen and drugs while the child is in mother's lap. Parenteral Dexamethasone is again life-saving, what we call that. This does chemical tracheostomy in these children. So this just reduces the edema and acts fast and is really helpful. So dose is 0.6 milligram per kg. Single dose may be helpful in these patients. So this was about 3 emergencies that I've thought might be seeing in office practice. I would like to show some videos that have been provided by Sir.
To administer the medication, support the head and locate the buccal area by holding the chin and gently applying.
Yes, sir. Yeah. Definitely, it can be given.
For office practitioners, I think.
Yeah.
And the IV, the oral prednisolone would be.
Agreed. Oral prednisolone, if available, this, I mean, it's always available. So, I mean, I think we should all have a kit in our clinic, an emergency kit, which should have at least oxygen cylinder. Oxygen cylinder is must. बाकी चीज़ें होती है लेकिन सिलेंडर फिल नहीं होता. So that should be there.
के बाद वो रखते हैं.
चलिए अच्छा है सर. और नेबुलाइजर होना चाहिए, एपिनेफ्रीन होना चाहिए, नॉर्मल सलाइन एंड सम स्टीरॉइड्स. So these are the drugs which will probably help in majority of the emergencies.
And the maximum dose of the nebulized adrenaline, that means would be 5 ml of the undiluted adrenaline. Just to re-emphasize.
Yes.
One point regarding Dr. Sethi has asked that in your previous slide you told that the steroid take at least 4 to 6 hours to start his exercise.
Yeah.
But in case of this
Croup you can give immediately.
So would it not be better to give the steroid as a nebulization also, because you are giving adrenaline as a nebulization?
सर स्टीरॉइड नेबुलाइजेशन का बहुत ज़्यादा रोल अभी नहीं आया है. एजमा की भी कुछ स्टडीज़ में स्टीरॉइड नेबुलाइजेशन फॉर अक्यूट स्टेज एक्ट करता है. एमडीआई एटसेट्रा they are more like whatever nebulized or inhaled steroids, they are more of preventive use. अगर आपको उस टाइम की प्रॉब्लम प्रिवेंट करनी है तो बेटर है कि सिस्टमिक ही दें हम. सिस्टमिक में यू कैन, प्रेडनिसोलोन इज गुड इनफ, डेक्सा इज समथिंग विच कैन बी यूज. अदरवाइज अगर आप उस टाइम पे दे देंगे तो एटलीस्ट आफ्टर 2-3 hours it will definitely start reducing the inflammation and will be helpful.
And is there any problem in giving intramuscular steroid?
इंट्रामस्कुलर स्टीरॉइड्स का कोई मुझे नहीं मिला. लाइक आप डेक्सा दे सकते हैं. डेक्सा इज समथिंग.
So that's in the last slide that Dr. Gavi asked that whether how can we use the IV? We can use the IM also.
डेक्सा IM देते हैं. मिथाइल प्रोडनिसोलोन नहीं देना है हमको. हाइड्रोकॉर्टिसोन नहीं देना.
Dexa can be given. That is 0.6 milligram per kg. We can give the steroid.
Definitely.
I think what the literature says is the oral steroid also, or the IM, whatever you're using, they do start acting immediately. It's only the optimum effect that takes 4 to 6 hours. But they do start acting. So even in status asthmaticus or the flare-up,
you have to give it the first.
Oral prednisolone as soon as possible. So they do start acting.
हाइड्रोकॉर्टिसोन मैम देना मुश्किल है. IV देना होगा आपको. तो इसीलिए वो बिकॉज ऑफिस प्रैक्टिस में हम लोग एज फार एज पॉसिबल IV अवॉइड करना चाहते हैं, इसलिए वी हैव नॉट इंक्लूडेड. बट अदरवाइज नॉट फॉर क्रूप में डेक्सा का रोल है. बट आप एजमा का कोई केस है उसमें आप दे सकते हैं हाइड्रोकॉर्टिसोन अगर आपके पास IV फैसिलिटी. हाइड्रोकॉर्ट की डोज सो मैक्सिमम हम 10 milligram per kg इज द स्टैट डोज फॉलोड बाय 5 milligram per kg एवरी 6 hours. बच्चों में आप 100 milligram तक दे सकते हैं उसको. So every 3 to 5 minutes it can for croup you are asking, not for anaphylaxis. Croup sir, every 20 minutes I think you can give it. Sir, कितना है frequency उसकी? Every 20 minutes, I think you can repeat it.
The purpose of these are very common medical emergencies which one encounter actually. The last one Dr. Preparedness was discussing was a croup, right? In croup, steroids, in whatever way you give, whether you give nebulization, intramuscular, oral, right? Some effect may start within 1 hour, but the peak effect, as Dr. Sethi told, comes at 6 hours, right? So it doesn't matter whether you're giving nebulized or oral or intramuscular, it takes that much of time. Nebulized steroids doesn't have faster effect, right? It's only mode of delivery is different, number. Second, in which cases of croup we should use steroid? Mild, moderate or severe?
Moderate to severe.
Not for mild, and severe would be headed to the hospital, so
So this is a confusion actually. In fact, steroids should be used in all three cases. Mild, moderate, severe. Purpose of using in mild is so that it doesn't become moderate or severe. So here we are not using a very 5 days course. A single dose of steroid is more than sufficient, right? So a child with a brassy cough and doesn't have stridor on rest, but if I got a stridor on crying, है ना? बच्चे normally better नहीं होता, जब रोते हैं तो एक stridor आता है ना? That is mild, right? So even those cases, one dose of steroid should be given. Second, regarding adrenaline, people use it in mild actually. The role of adrenaline is basically in severe or moderate. Not much role in mild actually. The purpose of giving adrenaline is so that it immediately reduces the swelling actually, which is more in moderate or severe. So हम जनरली उल्टा करते हैं, माइल्ड में एड्रेनलिन दे देते हैं, स्टेरॉइड नहीं देते हैं, है ना? और सीवियर वालों को तो शायद दोनों देते हैं.
इसी कंसेप्ट में जब एड्रेनालिन लोकली एक्ट करता है तो स्टेरॉइड लोकली एक्ट नहीं कर सकता.
No, the onset of action of adrenaline within minutes actually. Steroids अंदर जाके बाइंड करता है, इसे एंटी इन्फ्लेमेटरी बॉडी, it doesn't act actually. इसलिए हम जब अस्थमा होता है तो inhaled steroids are never drug of choice for acute asthma, है ना? Because they take little time. It's always beta agonist which are useful. So croup के अंदर तो ये दो चीज़ें हैं कि किस चीज़ में स्टेरॉइड देना, किस चीज़ में एड्रेनलिन देना और कितना देना, है ना? So the second scenario was, you're going to show some video?
Yeah.
Depend करता है कि आप कितनी quantity use कर रहे हो. Make a volume around 3 to 5 ml at least.
Volume for nebulization should never be 5 ml से कम. That will not
तो
be
अगर 0.5 मिलीग्राम पर के
normal 0.9% normal saline or 3% normal saline.
अच्छा 3%. अच्छा sorry I didn't. Normal saline, no, not 3%. 3% is basically for bronchiolitis. 3%? Bronchiolitis only. No. I think we never used it actually. Not studies. Hypertonic saline is never used in, nobody used, maybe it is useful, but I have never tried myself.
Yeah.
Beautiful.
Ma'am, ultimately these are
mostly
again
nebulized Budicort. That also in a very high dose actually, है ना? 1-2 milligram nebulized Budicort you have to give at least.
This is the only place where nebulized steroid is recommended. In asthma, nebulized steroid is not recommended. There, inhaler is the only way that we should be using steroids, but for group, the nebulization is the
So there are some small
Administer the medication, support the head, and locate the buccal area by holding the chin and gently applying downward pressure on the lower lid. Insert the syringe into the patient's buccal cavity. Do not put the syringe between the teeth. Push the plunger of the syringe slowly. Ideally, half the dose should be placed into each buccal cavity, but if the patient is lying down and access to the second cheek is difficult, administer the full dose into the uppermost cheek. Support the patient's head and gently close the mouth. Wait for 5 minutes for the epistatus to work and the seizure to become less active. The seizure should end within 10 minutes of administering epistatus. Patient recovery times can vary. Some recover quickly, others may remain drowsy for some time. If the seizure persists beyond 10 minutes, or the patient's breathing becomes shallow or irregular, call an ambulance immediately. Once the seizure has stopped, and if the patient is seated, let them stay in the seat to recover. Alternatively, if the patient is on the floor when the seizure stops, put them into the recovery position. While the patient is recovering, refer once again to the agreed patient care plan, where you will find
seizures. It is unpredictable, unmanageable. Stay calm. Make the person as comfortable as possible. Consult your doctor for advice or management of seizure emergencies. Midazolam 1.25 nasal spray is to be used only on the prescription of your doctor. To use Midazolam 1.25 nasal spray, please follow these step-by-step instructions. Shake the bottle gently and then remove the protective dust cap. Hold the bottle with your forefinger and middle finger on either side of the nozzle and your thumb underneath the bottle, as in the video. If using for the first time, spray it 6 times in the air, with the nozzle pointing away from the patient, until a consistent mist of the drug is delivered. This is an important step called priming, which helps to ensure that the correct dose is delivered. If the patient is in a supine position, the head should be slightly lifted upwards. The device should be placed near the patient's nose. Now, insert the nozzle into the nostril. Depress the pump with a firm, even stroke. The patient need not inhale. Do not tilt the patient's head backward while spraying. This will avoid swallowing of the solution. Administer 1 spray at a time into each nostril. You can continue as per the prescribed dose. Please note, you must reprime the device for subsequent use if the bottle is not used for more than a day. Spray it 2 to 3 times in the air, with the nozzle pointing away from you until a fine mist appears. Midazolam 1.25 nasal spray has 16-meter doses to be used as per the advice of your doctor. If the device needs to be used more than once, then the nozzle and the dust cap must be washed before storage.
Thank you. आते हम लोग.
Now it is available.
Brand sir.
Hello.
Midazolam. सिप्ला का है तो I think होगा.
I think साल डेट तक कुछ मिलेगा था तो एक मेडिस्टैट मिल रहा है मेडिस्टैट और इनसाइड भी कभी-कभी मेडिस्टैट also.
Regarding seizure control, as Dr. Penna told, basically IV in our office practice, we can use the IV, and putting IV in our office practice can be used, and other nasal, the other is buccal, third is rectal, and 4 is intramuscular. Right? First 3 are much more easier than intramuscular, of course. And let me take one by one. Nasal, which is the most preferred route, right? And how much dose you use? कितने पफ दोगे, है ना? तो सीधा सीधा फार्मूला है 2.5 किलो के लिए 1 पफ देना, खत्म बात. For every 2.5 kg, give 1 puff. That is the easiest to remember, है ना? ठीक है. और जो पफ दोगे उसके अंदर एक ध्यान रखना, सारे पफ एक साइड नहीं देने, है ना? Give 1 puff on this side. Wait for few seconds. Give the other puff on this side. अगर मान लो 4 देने हैं तो अल्टरनेट करके देने हैं. एक ही साइड 4 मत देना, क्योंकि एक साइड 4 दोगे तो आधी ड्रग गले में चली जाएगी, है ना? And what want to use is nasal mucosa. If you're using both sides, you're using larger surface area. Same second route, buccal. Sometimes people confuse buccal with the sublingual. Buccal is between the this mandible and this thing, not sublingual. ये surface area ज़्यादा होता है, sublingual में कम होता है surface area. So always place between the teeth and the cheek, not under the tongue. Okay? And try to use both sides, again to use larger surface area. Third thing, rectal, है ना? There are separate preparation for rectal, which is not available in India, but either we can rectal suppository, which is also sometimes not. Even normal diazepam you can use rectally. You can use 5 milligram less than 2-year-old child, and 10 milligram more than 2-year-old child, if you don't want to calculate the dose. It is so safe, right? But जो rectal दोगे उसको always make the volume at least 5 ml, है ना? Take a NG tube, insert inside the rectum at least 4 to 5 centimeter. क्योंकि rectum में देना है, NS में नहीं देना है. Remember the fact. If you leave it at the NS, the drug may not get absorbed and it may come out. So at least 4 to 5 centimeter inside the rectum, है ना? Beyond the NS आपको जाना है, rectum में जाना है. ये ध्यान रखना है इसके अंदर. तीसरे, है? Intramuscular, the only drug which can be used intramuscular in seizure is Midazolam. IM दे सकते हैं. Now in clinical practice, there are 2 kinds of patients with seizure, है ना? For management plan. Number 1, those who are coming seizuring to your clinic. Number 1. Second, a child sitting in your clinic and start seizuring. Are these different? Yes, these are different. Any child who is coming to clinic with seizure is assumed to be status epilepticus. Give the drug directly. Don't wait. है ना? But a child was sitting normally and start seizuring in front of you. In this case, you can prepare the drug, but don't give it immediately. You wait at least for 2 or 3 minutes. Because 80 to 90% of seizure get control of themselves without giving any anti-seizure drug. Right? So दोनों ग्रुप अलग हैं, है ना? मिडाजोलाम की इंडिकेशन क्या है? स्टेटस एपिलेप्टिकस. एंड स्टेटस एपिलेप्टिकस की डेफिनेशन क्या है आजकल? ए सीजर मोर देन 3 or 5 minutes. So each case of seizure doesn't need this thing. ये third scenario which Dr. Prerna discussed was anaphylaxis.
Sir, direction of nasal spray should be straight or outwards?
Outward करोगे तो ज़्यादा surface area मिलेगा. But whichever way you go, मिल जाता है इतना surface area. पढ़, हाँ? बक्कल की अलग आती है वैसे, हम तो सेम यूज़ कर लेते हैं. हाँ, जो इंजेक्टेबल मिडाजोलाम होता है वो यूज़ कर लेते हैं. पढ़, फॉर बक्कल नो डोंट डाइल्यूट एक्चुअली. जितना ज़्यादा वॉल्यूम होगा तो इंजेस्ट कर जाएगा, है ना? एंड द रूट वांट टू यूज इज बक्कल, इसलिए वॉल्यूम ज़्यादा नहीं होना चाहिए. जितने भी ये 3 रूट है ना, एक्सेप्ट फॉर रेक्टल जिसमें हमको 5 ml चाहिए, बाकियों में वॉल्यूम ट्राई टू कीप वॉल्यूम एज मिनिमम पॉसिबल, नहीं तो दे विल गेट इनटू द स्टमक. है वहाँ पे इतना वॉल्यूम चाहिए, इसलिए चाहिए होता है कि वहाँ पे पूरा सरफेस एरिया जो है तुम्हारे पास, यहाँ नेजल और बक्कल में सरफेस एरिया बहुत कम है, रेक्टम में सरफेस एरिया ज़्यादा है ना? ठीक है, नहीं तो आपके कैस्टर में सारा वॉल्यूम रह जाएगा अगर उसको डाइल्यूट नहीं करोगे तो, 5 ml नहीं बनाओगे तो, है ना? हाँ, 0.5 मिलीग्राम. लेट हो जाएगा. चलो ठीक है, एक बस मैं इनको एड्रेनलिन के बारे में, एनाफाइलेक्सिस के बारे में कर देता हूँ. इन एनाफाइलेक्सिस ऑलवेज जब हम इमरजेंसी की बात करते हैं, एयरवे ब्रीदिंग सर्कुलेशन की बात करते हैं. इन एनाफाइलेक्सिस ए स्टैंड्स फॉर एड्रेनलिन. रिमेंबर द फैक्ट. डोंट रन फॉर एंडोट्रेकियल ट्यूब एंड अदर थिंग्स. Adrenaline is the most important drug. Here is the situation where D stands before A. The drug which is going to help you is adrenaline. So there are 7, मैं कहता हूँ, I just read directly in my last presentation. So take home message for anaphylaxis. 7 tips, 7 फेरे हो तो याद रख लेना, है ना? In anaphylaxis, number 1, always administer. Number 2, intramuscularly. Number 3, anterior lateral thigh. Why anterior lateral thigh is important? Because there is a larger surface area and it is a highly vascularized muscle and want the adrenaline to be get absorbed fast. Always prefer intramuscular rather than IV, even if IV is available. But chances of complication with IM are much higher. So IM is the route of preference, even if IV is available. Anterior lateral thigh, adequate dose. Less than 6 ER, 0.25, more than 6 ER, 0.5. अगर पॉइंट उसमें नहीं कैलकुलेट करना तो 0.25 and 0.5 is okay. Agile मतलब फास्ट देना है ना in anaphylaxis. There are 7 tips, right? ठीक है, airway breathing is important, है ना? But adrenaline is the most important drug. नंबर 2 कई बार कंफ्यूजन होता है कि एनाफाइलेक्सिस, मान लो मेरे को डाउट है, सिंकोप है कि एनाफाइलेक्सिस, तो मैं क्या करूंगा? तो क्या करोगे? Give it, don't delay it. Even if you give adrenaline to a child with syncope, it's not going to harm it. But if you don't give it, it may be a life-threatening situation, right? And then send the child home. Only this much. Thank you. Sorry, I've taken a little more time, but only adrenaline. The 7 tips are only related to adrenaline, nothing else.
These are all second line drugs.
Second line.
Like once you have treated the patient and they are still.
अब बात होती है कि एड्रेनलिन की जो लाइफ होती है, शेल्फ लाइफ बड़ी छोटी होती है ना, लेस देन 1 ईयर. तो अपने क्लिनिक में जब रखते हो तो मोस्टली एक्सपायर कर जाती है ना. तो अपने मोबाइल के अंदर रिमाइंडर लगा के रखो, जिस दिन एक्सपायर होने वाली उससे 1 दिन पहले का, राइट, कि माई एड्रेनलिन इज एक्सपायरिंग ऑन दिस. सपोज आपके एड्रेनलिन एक्सपायर हो गई है और एनाफाइलेक्सिस हो गई, तो क्या करोगे? Are you going to use it or not use it? Use it, actually. Even expired drug got an efficacy of 60 to 70%, है ना? And they do not pay medical legal cost. It's well known. Can you attach this one? Thank you, Dr. Preparedness, for wonderful presentation. So now we'll go on to the next. लैपटॉप लगाना है.
The next topic is wound management, non-suturing techniques of wound closure.
आप में से कितने लोग CLW देखते हो क्लिनिक्स के अंदर? या नहीं करना पड़ता.